This week on the Backtable podcast.
Sense of community is real. I think some of the biggest factors that play into the depression are isolation, the challenges with getting back to social life, as far as whether it's communication issues or, let's face it, almost anything social, revolves around eating and drinking. And so it's very difficult, for many patients to get back to that quality of life that they knew before. And oftentimes it kind of leads to this vicious cycle of, more social isolation and then less kind of mental health as a result of that. And so I think many of the kind of support organizations and the programs now that are more active are really trying to incorporate, whether it's a patient mentoring aspect or kind of these chat rooms where people can go in and really talk to other people who have had a similar journey. And also kind of awareness programs and webinars that are created to make sure people know, one, they're not alone. What is it that they can do to try and tackle some of these things that are greatly impacting them?
Hello, everybody, and welcome to the Backtable ENT podcast. My name is Gopi Shah. I'm a pediatric ENT, and I have two amazing guests today to talk about survivorship and head and neck cancer. Let me introduce my guests. We have Dr. Heather Starmer. She's a speech and language pathologist and professor at Stanford University, specializing in swallowing and communication disorders in patients with head and neck cancer. And we have Dr. Michael Moore. He's a head and neck cancer surgeon and professor of otolaryngology at Indiana University. Welcome to the show, guys. How are you?
Doing great. Yeah, thanks so much for having us.
Doing great. Thank you. Happy to be here.
Yeah, thanks for coming on. Before we get into our discussion, can you tell us a little bit about yourselves and your practices?
Sure. Okay. So, as you mentioned, I'm Heather Starmer. I'm a speech pathologist at Stanford, and I've been working with head and neck cancer patients for about 25 years now as a speech language pathologist. And my clinic interest and my research interest are all around optimizing functional outcomes, whether communication or swallow function. I am fortunate to be the co-chair of the Survivorship and Rehabilitation section for the American Head and Neck Society and on the board of the Head and Neck Cancer Alliance. And so education and survivorship are my passions. And in my practice, I work alongside our surgeons as well as our radiation oncologists and medical oncologists to provide comprehensive multidisciplinary care all the way from diagnosis through survivorship.
Yeah, and as Heather mentioned, we're all part of one big multidisciplinary team. I practice out of Indiana University in Indianapolis. I'm a head and neck cancer surgeon. About half my practice is cancer removal surgery, and the other half is reconstructive surgery. And we work very closely with our local providers in medical and radiation oncology, and obviously speech language pathology, rehab, our dental team. Not only to get patients educated on the right approach to treatment for them, but get them through their therapy and then obviously support them during and after therapy in their survivorship journey. So I'm really excited to help raise awareness of the importance of this part of care.
Yeah. So when we talk about survivorship in head and neck cancer, when did this kind of come to the forefront? I don't recall kind of thinking about this in my training 10, 15 years ago in residency. And two, are we thinking, is this mostly to squamous cell carcinoma of the head and neck, or is it any cancer in the head and neck when we think about survivorship?
I think from my perspective, there were kind of two things that happened sort of in a serendipitous timeline. There was a report that came out in the 90s that was called Lost in Transition, and it was about how survivorship needs were not being met across cancer, not just in head and neck cancer. And about the same time that came about and the National Cancer Institute was really starting to focus on it, we also had this rise in incidence and awareness of HPV cancer where patients had higher cure and therefore longer life and therefore more survivorship concerns. So I think those two things together really brought the focus on survivorship, whereas for so many years it was about, 50% of people are not going to survive. We need to focus on cure and only cure. And so it sort of came together at that same time. And I think those are things that sort of brought that focus in the past 20 years or so.
Yeah, and I think that's exactly right. I think in reality, I think it's important just to start with defining what survivorship is. I mean, essentially, it starts when you're diagnosed with your cancer and ends, essentially when you pass away. And people who are cured from their cancer would fall into that category, but even of those who are still fighting the journey along the way. And I think it just highlights so many important aspects of the kind of patient continuum. Obviously, the stress and strain that comes, around the time you're being diagnosed and the support you need during treatment, but then obviously all that goes into the period of time dealing with not only acute but chronic side effects afterwards, and really trying to not just take into account being cured, but also what's the quality of life, when you're done. And it's kind of revolutionized how we look at this too, because there's so many different tools that are used that can look at and actually objectively measure survivorship outcomes as far as, quality of life and functional results. And I think that's allowed a lot of the new research efforts to try and quantitate that and see what types of treatment approaches are better serving our patients.
Yeah, that's interesting. So it starts right with the diagnosis, because it's not even that I have to have a quote cure to then be a survivor. It's surviving the diagnosis, the management, and then until from day one till when I die. So it's the whole. It's part of it when they walk in the door. Are there, just to kind of give us some numbers, when you think of head neck cancer, is there like an overall percentage of 5-year survival, or does that really depend on the type of cancer? Like if you're kind of talking about it broadly.
I think it's a heterogeneous group of diseases, to be honest. I think the number that Heather quoted is certainly, if you look at all comers, people used to quote the number of 50% would have a long-term survival. In reality, there's some groups, patients with HPV-related disease, the majority of them, unless they have the unusual scenario of distant metastatic disease, most of them will have an 80 to 90% long-term cure rate. Thyroid cancer, well-differentiated thyroid cancer obviously has a very high cure rate. But some of the other, what are called HPV-negative throat cancers and mouth cancers, those can be much more aggressive. A lot of that depends on, the stage at diagnosis, and that has a big kind of impact not only on survivability of the cancer, but also the functional impact that their treatment would have on them, and the quality of life they would have after treatment.
And is it still like the 5 years that's kind of the number that we use in terms of the time at which we think that's, we've had a
Yeah.
good outcome? Like, where's that needle? Is it still at 5 years?
Yeah, I'll comment and then get Heather's thoughts as well. I mean, that's a number that most of us, I always say I don't formally do backlips, and I don't do that anymore anyway, but 5 years is a very important milestone. I think, to be honest, 2 years is very important. At that point, once you get past 2 years, it's a much lower likelihood that the cancer is ever going to come back. But there are certain cancers that have a bit more of a slow growth pattern, a little bit more indolent, certain salivary cancers, for example, where we never really consider you cured. We always want to follow you very closely, to make sure nothing pops up down the road.
Yeah, I think that's absolutely right on. And I think one of the things that happens at that 5-year point is oftentimes I'm having the conversation with patients of, the good news is that we're less worried about cancer coming back, but there are other things we need to keep an eye out for. And so the shift goes from sort of watching for cancer to now watching for other things that can come up based on the kind of treatment they had, which I'm sure we'll dive into deeper. So I think our focus sort of shifts from a surveillance of cancer to a surveillance of function and quality of life.
Let's get into that to more detail. What kinds of challenges or morbidities that are commonly faced in our survivors, and how does timing play a role?
Yeah, I think one of the biggest things that comes up, or the two biggest things that come up in study after study, and certainly are true in my clinical practice, are swallowing dysfunction, dry mouth. I think those are the two things that are the most common and have the most impact on quality of life for many of our survivors. And from a swallowing perspective, I'll focus on that part since that's my area, but swallowing can kind of fall into three different buckets. So we sort of have the acute swallowing issues that happen right around the time of treatment. We can sort of have chronic issues where patients will never really fully recover. And so they're always dealing with some level of decline of their swallow function. And then we can think about more the late onset swallowing problems, and those can happen at any point. So, sort of by definition, as swallowing specialists, we think about the late swallowing things or something that happens after they recover from those acute toxicities. So, they have a period of relatively good function, and then all of the sudden things start going in the wrong direction. And that can be a year after treatment. That can be 20 years after treatment. So I've seen it in, really long periods of time post-treatment as well. And those are the hardest ones to deal with. So we have the most ability to impact and change acute and the chronic issues, and we have less ability to impact those late effects. And so that's one of the things that we want to keep looking for in our survivors is onset of cranial neuropathies, which are one of the classic hallmark signs of late radiation dysphagia, either hypoglossal palsy or vagal palsy. So we're always wanting to keep an eye out for that. If we can catch it earlier and work with the patient, we may be able to mitigate impacts such as pneumonia, which has been implicated as a potential cause for late mortality related to head and neck cancer. So we can really think about swallowing sort of across those sort of three main groups.
And is that usually gonna be speech therapy to kinda help, especially with that late onset group of patients?
Yeah, in the US, I would say that the majority of this, at least, the diagnostics are predominantly within the realm of speech pathologists. There are some otolaryngologists who are really interested in this, and certainly they play a really valuable role. Unfortunately, there's just not that many of them. So a good call for other, trainees who maybe want to be interested in dysphagia. We could use more of you. But yeah, certainly speech pathologists do a lot of diagnostic work, both in radiology and with endoscopy. There are certain things that need to be managed surgically. So stricture, for example, in patients that have truly intractable aspiration and multiple complications, we may be looking towards things like functional laryngectomy. So there are definitely cases where we need to be enlisting the help of our otolaryngologist. And then there are other situations that we need to manage through some sort of exercise intervention, using different kinds of compensatory strategies or mechanisms, doing skill training, respiratory recoordination therapy. So there are a lot of different things we can try to control those dysphagia symptoms from a speech pathology perspective.
Mike, do you see these patients in your clinic that are late onset dysphagia, and how do you tend to manage them?
Yeah, I do. To be honest, the majority of the time are instances where I followed them, during their cancer journey, and I'm continuing to follow them for surveillance afterwards. I don't see as many that are kind of, they've been treated and are coming primarily for the diagnosis of dysphagia. In those instances, obviously, we work very closely with our speech language pathology team, but also our laryngology team. So folks who are kind of speech and swallowing experts that, these patients have been, a lot of times I'll evaluate the patient, make sure they have no evidence of obvious cancer, have the laryngologist see if they can work some magic, if you will, in combination with our speech language pathologist. Obviously, in some instances where it really is something that they really hold eating and drinking as one of their highest priorities, yet they're continuing to suffer from, chronic aspiration. And occasionally we have the conversation about functional laryngectomy, and on those, we'll usually get back involved with those as well. But yeah, as far as a primary assessment of radiation dysphagia, I'm not usually the provider. A lot of times, at least in our institution, it's the laryngology team.
And Heather, you'd mentioned dry mouth. What kinds of tips or tricks? How do you help those patients?
It's a tough one because there are not a lot of great options. A lot of it is just symptom management. So xylitol is an active ingredient in a lot of different things. Sugar-free gum. There's lozenges called Xylamelts. Those tend to be the ones that my patients like the best. There's lots of biotine products. They're all very temporary. And so you use a spray or you use a gel, and it gives you about 15 minutes of relief. And for some people, that's good enough. They can, they don't mind spraying and reapplying frequently. And others, I think it's more hassle than it's worth. The nice thing with the Xylamelts is they slowly dissolve. And so people find a little bit more of a durable, a longitudinal benefit from that. But, it's things like using a humidifier when you're sleeping at night and adding sauces and gravies to your food so your food is moist and not dry. It's a hard one because it's everybody gets it at least during radiation, and then the majority of people have at least some degree long term.
What are some of the other, so we talked about dysphagia, dry voice. What about mobility in terms of, I don't know, shoulder, physical, after some of our recons? What are some of their challenges?
Yeah, I mean, I can comment a little bit, and then obviously Heather can comment a bit on how their teams help with addressing them. But a lot of that depends on the therapy they have. Certainly, shoulder weakness is most common after surgery, working around the spinal accessory nerve. Even if the nerve is preserved, it's not uncommon to get some transient stiffness of the shoulder. And it's very important to get those patients working with a physical therapy team early on. Obviously, neck fibrosis, kind of chronic neck pain just from disrupting the cervical plexus. And just to be honest, just the trauma of treatment, whether it's surgery or especially if you're combining it with either preoperative or postoperative radiation or chemoradiation therapy, those patients all get a fair amount of stiffness and impact, related to that. One thing I think is very kind of closely tied into that, but not the same thing, is, lymphedema. But a lot of the similar approaches to the neck stiffness and fibrosis can also be used to try and help with some of the lymphedema management. And I think, and this kind of ties into what we were just talking about, the dysphagia part, there can be lymphedema on the outside, but also lymphedema on the inside, what's called internal lymphedema. And, the nice thing is, by approaching them with kind of external lymphedema therapy, a lot of times that provides some additional benefit to their swallowing function as well.
Those are really good points. And I think one of the things that I didn't realize probably until a number of years ago is many of our patients are completely scared to move and or touch their neck after surgery and after radiation. And so they get in this frozen position, which just complicates all of these issues with the lymphedema that's happening, the fibrosis that's happening. So I think all of us want to really be sure that we're getting our patients moving their neck, not feeling scared of touching that neck dissection scar. Once it's healed, we want them to start moving it. We want them to do scar massage. We want to get lymphedema therapy on board. And the earlier we do all of that, the better. And I think that lymphedema is probably an area that has a huge potential to make a big mark in terms of improving quality of life. But I think it's an area that has been under-recognized and under-treated for a long time. And so depending on where you practice, the management of that may be with physical therapy or occupational therapy. It may be with the speech therapist. And whoever is the local expert is the person who should be treating those patients. But I think it's a really good point that it's not just about the mobility, but it also does impact swallowing and voice and breathing as well.
If a patient does need lymphedema therapy, when would they start? Is this like 6 to 8 weeks later? Are we talking several years later, waiting until the symptoms come? Is it part of the PT?
Yeah, the earlier the better, I would say. Most of the time in a post-radiation setting, lymphedema really becomes apparent around the 3rd month post-radiation. And we try to get them started right as soon as we start to see signs of it. Surgically, often, you sort of have that postoperative edema. And then when is the point where we transition from normal post-op edema that's going to go away to lymphedema? We usually look for about a 6-week period for that acute edema to resolve. And so if somebody's having surgery and not radiation, probably starting lymphedema somewhere around the 2nd month post-surgery. But in some cases, we need to do it sooner. So you'll see those patients who have very, very severe acute edema. They can't open their eyes. Their lips are really swollen. Those are people who we may start working on. Even though we know it's acute edema, we've got to get the burden of the edema down. So certainly in some cases, we start very early.
Dysphagia that might be caused by lymphedema, does it have a specific presentation to it? Is it more with liquids, food getting stuck, choking? Have you noticed anything?
I would say it's very similar to what we see sort of across the board, even for those without. Usually what we're seeing in terms of the internal edema and the link to swallowing function is when the laryngeal structures are swollen, so the epiglottis, the area epiglottic folds, the arytenoids, we start to see obliterations of those normal pharyngeal recesses. So the vallecula gets filled with edema, the piriform sinuses get filled with edema. And then on top of that, they're sort of losing out on some of those pharyngeal propulsion forces. So you've got residue, but now the residue has nowhere it can sit. And so that residue then ends up spilling into the airway, and that's where we get penetration and aspiration. So most commonly what we see is sort of after the swallow issues where stuff is just stuck and it has nowhere to go, and the airway's the path of least resistance.
Mike, you had mentioned chronic neck pain from fibrosis and things like that. Do a lot of these patients have chronic pain that are, 5 years out of treatment, 2, 3 years out of treatment?
Yeah, they certainly can. There are some studies to show that patients who come in with chronic opioid use can obviously be a bit higher risk for that. But there are a lot of different, reasons why they may, be still having chronic pain. Obviously, first and foremost, you want to make sure it's not related to a malignancy or recurrence or any sort of traumatic neuroma or something like that was, involved in the surgery. There are patients who just will always still have chronic discomfort or hypersensitivity. I've found a lot of it is kind of patient dependent with how they tolerate that. Some patients expect to have no pain, whereas in reality, some baseline discomfort is not at all uncommon. Having had, a few minor surgeries myself, you're always going to know that's a part of your body that's been traumatized, but the head and neck is such a central part of everything we do. So when I'm talking to them about it, a lot of times I'm trying to distill down, is it a very focal thing? So occasionally you get muscle spasms, like in the platysma muscle or some of the strap muscles. Those, if they're refractory to physical therapy, sometimes you can consider Botox injections for that. And that, to be honest, can provide some relief. And then obviously stretching exercises are helpful. I'm not a big fan of heating pads just because a lot of times they're numb. And so you can put them at risk for some trauma related to that. It's more kind of massage. The institution of palliative care is a very reasonable thing. I think it's important to know palliative care does not mean that you're throwing out the white flag and not, even if they don't have cancer, palliative care can have a significant role. The job is to obviously try and minimize suffering of patients and optimize quality of life. And so it's not at all uncommon, especially for people with really challenging treatment-related side effects, to have the palliative care team involved. And they work very hard, to be honest, to try and, I think gone are the days where these are just opioid clinics. They're trying to find multimodal approaches, both, medication approaches, but occasionally interventional approaches to pain, whether it's certain injections or there are even, considerations where they can do certain, kind of implant procedures. I've not had a lot of experience with that in my institution, but I've certainly heard it's been done. And then there are other, again, more alternative approaches, patients who consider hypnotherapy or acupuncture as approaches to ways of trying to, address the pain, and obviously also working with to make sure that depression's not an underlying seed of that, because mental health and the head and neck cancer journey is a real thing, and that can obviously have a significant impact on your pain threshold. Sleep, all that ties in. Yeah, I think poor sleep, depression, that can also lower the pain threshold as well. Well, I think it tied in so much to what we were talking earlier as part of the therapy, but the dry mouth, and then obviously dental is a big issue with survivorship, is Trismus therapy. So that's one that you need to very much start early in the game. Waiting until the fibrosis is set in and the muscles of mastication, you're almost too late. And so those are ones that as soon as you're sure that the acute kind of surgical healing, which to be honest, even be as early as 2 or 3 weeks, have them working with it depends on the institution. Some places it's physical therapy or occupational therapy. Some places it's speech language pathology. But, if a therabyte's an option for them, that often can be a great help to try and help with mouth opening, not just to allow for good maintenance of dental care, but it helps a lot with speech and swallowing therapy, and also just their overall quality of life as far as the diet that they can resume as well.
Do you have a dentist as part of the team, or are there certain dentists in the community that are specifically like specialized in kind of knowing how to examine or kind of watch for some oral wounds, dental caries in these patients that have already had, radiation and things like that?
We do. We're spoiled. We have a great hospitalist dentist that helps with the assessment of a lot of our patients. But in reality, as many kind of tertiary referral centers are, you're caring for people all around the region. And so the vast majority of the time, to be honest, outside of that initial assessment, if we're, for example, going to have surgery and we're saying, hey, are there any teeth we need to take out during surgery to prepare for possible radiation, they're working closely with their local dentist. And so, with them, we're usually encouraging, they see them obviously before treatment for pre-radiation screening. And then also I always say, if you're seeing them every 6 months, you'll probably want to see them about every 3 months. Consider, something like fluoride trays to try and, optimize your dental health. And, obviously, if anybody ever starts coming at you with the concept of dental extraction after radiation, I want to hear about it just so we can talk about it and see whether or not it's appropriate, just to minimize the risk of things like radiation necrosis and things like that.
And then kind of going back to mental health, who are our mental health partners, and what's the timing of getting our mental health partners involved with these patients?
This is a real challenge, just, as we see across medicine, right? We don't have adequate medical health support in the US, not enough providers. We are also fortunate we do have a psycho-oncology group that is very close physically to us, and we can get patients involved with them from the time of diagnosis. So if we have somebody who has baseline issues with depression, anxiety, and or they just develop them as part of their diagnostic process, we can try to get them involved with either our social worker as sort of the first step, and then our psycho-oncologist if they need more assistance. Once you get out of a major cancer center, I think it can be really challenging to find mental health professionals that specialize in sort of issues around cancer survivorship. So oftentimes we're also trying to make sure patients are aware of, support groups, because support groups are usually run by somebody in the mental health or co-led by somebody who's a mental health provider, and other organizations that maybe support organizations that can help as well. I don't know if you have other thoughts, Mike.
No, I think it's very similar, and I think that sense of community is real. I think some of the biggest factors that play into the depression are isolation, the challenges with getting back to social life, as far as whether it's communication issues or, let's face it, almost anything social, revolves around eating and drinking, and so it's very difficult, for many patients to get back to that quality of life that they knew before, and oftentimes it kind of leads to this vicious cycle of more social isolation and then less kind of mental health as a result of that. And so I think many of the kind of support organizations and the programs now that are more active are really trying to incorporate, whether it's a patient mentoring aspect or kind of these chat rooms where people can go in and really talk to other people who have had a similar journey, and also kind of awareness programs and webinars that are created to make sure people know, one, they're not alone. What is it that they can do to try and tackle some of these things that are greatly impacting them? But I do think we're just scratching the surface. We had a head and neck cancer survivorship symposium that we have every year, and last year, the one we did in Philadelphia was striking as far as how much the mental health aspect came up. There's actually even an upcoming webinar that's being developed through the Head and Neck Cancer Alliance and the Head and Neck Society that's focused a lot on this. And so I think it is something that, when you ask patients after the fact, they all wish that they had had that assessment before and during treatment. But if you were to ask them when they're sitting in your chair and you're telling them they have a cancer diagnosis, it's, to be honest, the farthest thing from what they want. And so I think that's really one of the biggest next steps we need to take is, when is the right time to have that conversation? How, for many things, prevention's the best way. And I'm confident that that's the case here as far as trying to support them during it. But in reality, there are some patients who may not be ready for that just yet, or they don't think they're ready until it's almost after the fact and they're playing catch up with it.
And I think the other piece that goes with that I didn't have a full appreciation of, I knew it was there, I just didn't have a full appreciation, is just how real the fear of recurrence is and how heavy that weighs on people. When I did some qualitative research around head and neck lymphedema, every single patient and every single caregiver, when lymphedema came on, they thought the cancer had come back. And so every time the smallest things happen, so I think one of the things we really also have to do is make sure that patients and caregivers also really understand what are true warning signs and what's just a cold, right? Sometimes it's just a cold, a sniffy nose. So I think making sure that we also really provide good education about, and then also access to somebody on the team who can help to dispel some of the concerns when things come up that are maybe not cancer related.
Do we have like studies or data that look at function or mobility, quality of life like 10 years out? Like do we have more of that in literature now? What are we finding?
It's pretty limited. I would say most of the data that is out there at that point in time are really looking at the people who are not doing well. So it is the people with the late radiation dysphagia. So I think we have a limited understanding of sort of the average person and how they're doing it 10 years. Most of the studies, sort of a long-term study is 3 to 5 years for the most part. So I think, we do know that there are quality of life issues, but I am unaware of really good, strong literature going out that far.
Do we have any guidelines yet or like an assessment tool for head and neck cancer survivorship or for survivors, or like a checkbox of things that we should be looking at, like 1 year after treatment, 3 years after treatment, or things that we now include in our initial assessment that maybe we weren't doing to kind of include that lens?
I would say yes, and I'll let Heather go into a bit more specifics. One thing we've not touched on, obviously, in the early period, you're usually seeing them about every 3 months. You're assessing almost at every visit, kind of the swallowing and dental care, obviously wound healing, and then also we do a distress screening to try and see, whether or not they have kind of any acute kind of psychosocial or mental health distress, and get them plugged in with the appropriate team members if they do. But also the thyroid. So once a year, you check a TSH. If they have a thyroid gland, you want to get a better appreciation of whether or not it's been impacted by. Usually, it's obviously with radiation therapy. If they've had that, then that would they would run the risk of getting hypothyroid, which could obviously manifest as more lymphedema and depression and a lot of things that would be kind of masqueraded by hypothyroidism. There are some great kind of tools and surveys that are implemented. I'll let Heather comment on that because I know she's very active at her institution on that.
There are a large number of different tools that can be used to sort of monitor for symptoms. I think there's one survey that's really nice that came out of the UK called the Patient Concerns Inventory. It's basically a checklist of all the different kinds of symptoms that people with head and neck cancer might experience. And it sort of gives the patient the opportunity to check off what they're experiencing, but also what are things they actually want to talk to the provider about. So there may be things like they're like, yeah, I have dry mouth. I've had dry mouth for 10, 12 years. I've tried everything there is to try. I don't need to talk about this anymore. Oh, but I'm having this fatigue issue that's new. And so it helps to contextualize for the provider to quickly look at like what's there and what's an active problem for the patient. So that's a really nice framework. There are many different things, the MD Anderson symptom inventory, the Vanderbilt head neck symptom index, all can sort of similarly give the provider a sense of what are active problems for that patient in that point in time. So I think those are all really nice tools to use. Another thing that I think is worth mentioning from a long-term perspective is also keeping an eye on the carotid arteries. And so doing ultrasonography, I know in our center, usually it's about 5 years out, but keeping an eye out for issues around ultrasonography, also baroreceptor failure is another late toxicity that we might see. So queuing patients in to keep an eye out for that. And then in our practice, we do an annual sort of gradual functional surveillance evaluation. So we're looking at swelling, we're looking at cranial nerve function, we're looking at any other general worsening that we might need to send them on to physical therapy or psychological oncology or whomever the case may be. And I know that's different in every institution.
And are there enough patients now where you have like a separate survivorship clinic that's like potentially multidisciplinary, or is that something I feel like other cancers have that?
Yeah. I think there are places where it exists. I know we have kind of had multiple false starts, so we keep trying to do it, and then it's always the question of who's involved and what patients are involved, and there are some cases where certain oncology providers say, "No, no, no, I want to personally see the patient myself. I don't wanna send them over to a nurse practitioner who didn't know them throughout the rest of their journey." So, we haven't been able to sort of formally implement that in our center. I know that like University of Pittsburgh is a great example of one program where they've got it figured out. It's multidisciplinary there where they have a head neck surgeon, a nurse practitioner, physical therapy, speech pathology, dietitian seeing patients. But that's obviously a big commitment of lots of manpower. Mike, how about you guys?
Yeah, we found, I think, a similar thing to you and others around, many others around the country. It's just logistically very challenging. The way ours works is, we follow them as a surgeon most of the time, 2 years out. Occasionally, we, transition them to our nurse practitioner at a little over a year, but it's usually 2 years out. When I do that, I talk to the patient about it. I say, this is a good graduation. And then I actually have the nurse practitioner come in and we do an exam together. We have 5 days of the week. We have a different surgeon in clinic every day. And so we have those survivorship patients come back and the nurse practitioner's clinic is literally right around the corner. So in the same clinic space, just different exam rooms. And so it's always, an option of they could just come tap us on the shoulder and say, hey, there's this new area that's been bothering them of concern. And then within our regular clinic, our speech pathologist is embedded in it. So they're seeing patients, along with us a lot of times, or they have their own room. So they're doing kind of functional assessments there. We don't have dental in our clinic. They're right across the hall. So very closely related to us. But a lot of that just depends on the individual patient. It's kind of like having a true multidisciplinary cancer clinic too. There may be plenty of patients who don't need to see medical oncology or don't need to see surgery or things like that. And so because of that, it's just been a challenge to really fully devote, as Heather mentioned it, the people power specifically for that. But the way we've done it, we've tried to find the right balance of still allowing them to kind of graduate to this next aspect of care. Because the nice thing about those visits with our nurse practitioners, obviously some of it's on the cancer surveillance, but a lot of it is like, what is bothering you? What do we need to do to make this better? And so really being able to sit down and take that kind of half hour, 45 minutes to tease out all these different issues. Whereas, With us, we're saying, oh yeah, it's great you don't have cancer, and we obviously try and implement steps to address any symptom management issues that come up. But I think with those, they're much more kind of a comprehensive approach to really making sure they're addressing those quality of life issues that are coming up.
I wanted to kind of get more into resources that are out there for other providers as well as patients. You'd mentioned the Head Neck Cancer Alliance. Can you tell us a little bit about the Head Neck Cancer Alliance?
Yeah, I'm certainly happy to start. Yeah, I've been involved with the Head Neck Cancer Alliance for a number of years. It is an organization that started primarily on kind of head neck cancer awareness and early detection and prevention. Happy Head Neck Cancer Awareness Month. This is April, and as a part of that, over the years, it's really evolved though to meet the patient around the time of diagnosis and provide a lot of educational resources to help them with determining the right treatment for themselves, and then obviously supporting them during and after therapy. So the organization has a lot of different resources available. The website is headandneck.org, but there are a lot of free resources there, everything from online kind of chat group that are, patients who are going to that site to kind of, ask questions and get feedback from one another on what's worked for them. There's a regular webinar series that's kind of a partnership with the American Head and Neck Society that has usually about once every 2 months a webinar on a different survivorship related topic. There's also a mentoring kind of setup where it's through Emmerman's Angels that the Head and Neck Cancer Alliance help facilitate. So if you get diagnosed with, for example, like an oropharynx cancer and you're going to get radiation and chemotherapy, they would pair you up with somebody who's had a similar treatment that could provide some insight to that. But there are a number of other great organizations that support people with oral and head neck cancer that they organize a lot of support groups around the country. The Thank Foundation, so the Thyroid and Head Neck Cancer Foundation, is another really strong organization. The Head Neck Cancer Living Foundation raises a lot of money to help with dental care around the time of patients' treatment, and then obviously the Oral Cancer Foundation as well. So I think there are a lot of different ones. The Head Neck Cancer Alliance has tried to kind of be one that's a bit more comprehensive, but at the same time, I think there are many other great organizations that are out there to help support people through the journey.
When do you provide patients with this information? Like, when do you say, hey, he should check out the Head Neck Cancer Alliance, or here's, the contact webpage for the dental care? I think you had mentioned it was the Living Foundation for dental care. When do you start giving patients that information? Because many patients may not realize that those are important resources to have. So what's the timing of that? Is that first visit? It's fifth visit?
Yeah, to be honest, I've started doing it very early on, and then I just revisit it. We have little QR codes where they can kind of go in and scan it to kind of learn about different things, and just trying to make it as easy for people as possible. For ones that are more specific, like the Head Neck Cancer Living Foundation, where it's more kind of dental focused, if you get a sense that that's a big barrier for them, then we'll introduce that. But that doesn't necessarily apply to all patients. But we have kind of a welcome packet when they first get diagnosed, and we provide that information with them. We also try and outline, we don't know maybe what your treatment's going to be yet. We may or may not have talked to them about it, just depending on their particular scenario. But we do talk to them about the fact that we're going to be following them kind of moving forward, and providing kind of regular support along the way. And I mentioned that, there may be times where you don't feel like this other information is necessary, but I just encourage them to look at it early on, because I kind of give them the anecdote that many of my patients say, geez, I wish I had seen this, when I was going through it, because it's, when they look back after the fact, they found it very valuable. So I mention that to people and then kind of let them go and check it out for themselves.
Yeah, we also we do the same thing, and I think the returning to it is really important. We also have it integrated into our electronic medical records, so the after visit summary, the links to those foundations are also there, so that if they're not interested at the beginning, they can always go back to it. And then the other thing for people who are not already, for instance, the Head and Neck Cancer Alliance does have a mailing list. So if you're interested in knowing about what webinars are going to be coming out, so that you can share that with patients, you can certainly get on the mailing list for that. And so you're knowing, what the different topics are that are coming out.
As we start to round things out, I wanted to ask one last question. Where do you see our future research or educational gaps, whether it comes in practice or research, for survivorship in head neck cancer?
Heather, you want to start with that one?
Yeah, sure. I think that long-term piece, I think it's great that we have data going to 3 to 5 years. But I do think that a lot of changes potentially can happen beyond that point. And there are certain things that we know tend to sort of stabilize around the 2-year point from a function perspective. But then some of these other things that we don't really understand, which is when somebody has a functional impairment that, let's just say it's 20%, right? They have 20% impairment in swallowing or 20% impairment in neck mobility. And then we add normal aging onto that. What happens? And so people who are compensating really well when they're 60 years old, 20 years later when they're 80 years old, how well are they compensating when they don't have as much functional reserve? So I think that is a really big area that we need to be paying attention to, is that because our patients are living longer and many of them have had radiation therapy, and we know that radiation therapy is the gift that keeps on giving, is we need to understand how that sort of interacts with normal aging. So I think that's a big area that needs some focus.
Patient-reported outcomes are a big next step. So really in real time, learning what they're experiencing, and just filtering that back to the treatment team. But obviously with AI getting more and more robust, how do we integrate that to really kind of identify things that may turn into a bigger issue, ahead of time? And I think a lot of work is going into that, but probably not enough yet, because I think in reality, people are just so focused on cancer cure, and the approach to therapy. But in reality, the quality of life and the other part of it is treatment regret. So, really retrospectively looking back at, you had this therapy, what are the biggest impact of your quality of life now? If you were to, for example, what detriment and survival would you be willing to take if you didn't have to have a feeding tube, or you didn't have to have X, Y, or Z things that are really impacting your quality of life moving forward. And I think that's one thing that's so exciting about kind of the community that we're starting to see with the Alliance and other programs, as we're getting survivors together and talking about this stuff. Obviously the mental health piece as well, because I think it's also closely tied together. How could we really kind of get ourselves in the mind and the head of the patient to see what they're experiencing, to see how we can make it better? And I think the exciting thing is, many of the pharmaceutical companies and other treatment related companies that are focusing on clinical trials, they want to know. They want to know what the patient journey is like. They want to know what the barriers are to getting patients to be considered for trials, and really, see how we can meet them and provide them the best service possible.
Yeah, and if I can add just to that really quick, I think, many of us who are doing research in outcomes and quality of life are clinicians, right? We're not lab scientists, we are clinicians. And so we're busy clinicians that are trying to balance sort of clinical research and clinical care. And so a lot of the work that we do ends up being, looking a lot at these quality of life instruments. But I will advocate for qualitative research and the need for more qualitative research in this area where we can dig deeper. Having done this recently in the space of lymphedema, learned a lot of things that, despite the fact that I've been working with head and neck patients for 25 years, were unexpected findings because of that extra time to really sit down and dig deep with people. So I think that is a methodology that we really need to be thinking about when we're thinking about survivorship and these big issues around quality of life. It's not enough to just do the surveys. We've got to go to that next level.
Well, this has been so great. Any final pearls or, anything else that you want to leave our listeners with?
Well, I think the biggest thing is it's a challenging journey, and when we're so privileged to be able to be a part of it, I think it's one of those things that it's really telling to learn, not just that some of what we're doing is working, but obviously how we can do it better. And so I think we all strive, myself, Heather, many of the other providers around the country who are trying to work as a team to see how we can better serve, patients affected by head and neck cancer. I think it's an exciting time. I think, I can't express how much things have changed. I've been in practice for 17 years, and how much they've changed. I can't imagine the next kind of 10 years and what we're going to see when we're talking about this, a decade from now.
Yeah, that's so true. I tell my students that all the time, that the world that we practice in now is very different than the world I practiced in 25 years ago, where we would see people only when they were devastated by the consequences of their treatment. And now we're much more proactive. And I think that's the big thing that I would want people to take home, is that the earlier we address the functional concerns, the more likely our treatments will be effective. The more we can do to prevent them, the more likely we are to prevent them. So I think really being proactive and not reactive is really critical for this patient population, and really we're all really busy and we all have these intense demands on our time, but taking that extra minute to really ask, the slightly deeper questions about what's going on with the patient so that you can pull in the right people who can help support them. I think those would be my big take homes.
Well, thank you so much, Mike, Heather. Are either of you guys on any social media in case anybody wants to reach out to you? We'll put the Head Neck Cancer Alliance link to our show notes as well as a resource.
Yeah, my main one would just be through the Alliance webpage itself. I don't have my own social media tags, so I don't know if Heather does, but I do not.
Yeah, I would say LinkedIn primarily from a professional perspective. I'm sort of trying to cut down the majority of the others right now.
That sounds great. And if any of our listeners want to reach out, they can always reach out to us and we can always connect you guys if necessary. But
that sounds great.
Yeah, thank you so much.
Of course. Thank you.
Yeah, appreciate you having us. Thanks so much.
Yeah, it was lovely.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _Backtable ENT on Instagram, LinkedIn, or Twitter. Backtable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz. Thanks again for listening and see you next week.